Hello, everybody. I'm Rob Wallace here in St. Paul, Minnesota. I'm an evolutionary epidemiologist with the People's CDC here with an update on the COVID-19 pandemic. With all that's been going on with the end of the federal public health emergency, we split this week's episode into two parts. In the first part, which you can find on the People's CDC YouTube channel, we covered the state of global COVID and the state of US COVID, including changes to what COVID data are still now available. In this second part, we'll review what the end of the public health emergency means big picture politically. One expects that an outbreak that has killed over 1.1 million Americans, and adding more every day, might reset priorities in the direction of strengthening our public health capacity. After 9/11, indeed to this day, we must run our sneakers through the X-ray at the airport after one failed shoe bomb. Instead, the political class has organized itself across bipartisan lines around rolling back public health in both concept and practice, even in the course of repeated infections among its own cadre. It appears public health and pandemic response beyond lucrative market solutions are considered by the political class too much a public commons for the American people. You must understand, goes the thinking, government is instead largely organized around making the rich richer. Accepting that contradiction serves as an occupational oath of loyalty at the heart of establishment public health. One must not wear masks or exercise other precautions when presenting on the need for exactly such precautions. The Washington Post reported a COVID superspreader event at a late April Epidemic Intelligence Service conference of 2,000 people CDC held at an Atlanta hotel. Among the presentations, the Post writes, were more than a dozen sessions on the lessons from fighting COVID, including how far we have come, a COVID-19 surveillance system evaluation, a session that discussed improvements on tracking the virus, end quote. The Post continues, in posts on social media, attendees at the conference were unmasked as they gathered in person. Some CDC staffers and alumni opted to attend virtually, worried about COVID risks, according to people with knowledge of the event, end quote. Now, it is no coincidence news of the outbreak was released on a late Friday, the black hole of the week into which all PR specialists dump their clients' worst outcomes. The Fed's pandemic response has largely been organized this way, from underreporting COVID's clinical and epidemiological damage to overselling our pharmaceutical interventions. Now, this is not a personal attack. The attendees are bright and compassionate people trying to do the right thing in the face of neoliberal governance. The Epidemic Intelligence Service needs new recruits. We want a working CDC that works for everyday people and not just for employers. But the outbreak at the conference speaks to the terrible nexus of social norms and technicist intervention that plays upon the very American exceptionalism EIS officers are routinely tasked to clean up. Indeed, well beyond public health officers slated for the field, we are learning that willful denialism and bonkers justifications aren't just matters of wingnuts, but also of what Tariq Ali calls the extreme center. Here's Michael Minna implying all will be well by 2070 when the newborns of today will have been infected by SARS-2 hundreds of times and will learn by then, quote, whether the virus behaves like a textbook virus. That's an extraordinary example of survivorship bias on the one hand. What of all those who never make it to 50 from all those infections? And it is also a hideous experiment in eugenics. One doesn't let a deadly virus loose to see what happens, even under the tenuous presumption that all will be well. As math teacher Chris Sardorn calculates on the back of a Twitter envelope, 47 years, 2 exposures a year, 10% chance of long COVID per exposure equals 99.66% of long COVID by the time they are 50. Now, Minna isn't some marginal creature. Ex-Harvard epidemiologist and now chief science officer at the eMed diagnostic company, Minna pushed the country's adaptation of rapid antigen tests. He's helped monetize a public health without public health. We appear very much on track to universalizing Minna's experiment, especially if, as in England, the US offers boosters only to those over 50 years of age, as Christina Pagel describes here. All newborns here and out wouldn't be vaccinated. It's immunologically sink or swim, little Timmy. Even as a new study shows, 12 to 16% of children and youth infected with COVID met the research definition of long COVID. There were minimizer subtweets trying to knock away the results shown here across symptoms, infection status, and time period on the basis that only 6% of invited parents allowed their children to participate in the research. But it's not whether 6% response is too small a chunk of the invited, but whether it still represents a random sample of the total population beyond the invited, and whether the 886 children who participated offer enough statistical power to distinguish first-time positives, the reinfected, and test negatives should an effect exist. And even if the research should be followed up on technical grounds, the minimizers are in fact trying to rub out the study based on its devastating implications alone. Not only do children get infected with COVID, but there's apparently a certain percentage that get long COVID as well. Now, this may be very much a reason why Rochelle Walensky unexpectedly quit her position as CDC director effective June. Once the public health emergency is lifted, all the damage to follow is very much part of the federal government's liability. Another way to respond to the unconscionable is to rewrite the history of the pandemic. If the now retired presidential medical advisor Anthony Fauci cops to David Wallace Wells in the New York Times Magazine that the US indeed suffered structural holes in its public health and medical care, for which he never identifies the source, he also strikes readers as the Robert McNamara of COVID. Fauci excels at a pantheon of strategic misdirection, conceding faults only upon his questioner's direct accost, using such concessions to negotiate exoneration elsewhere, likewise pretending he didn't know what he previously showed he knew, and misrepresenting the pandemic's documented history. For instance, upon Wallace Wells' observation that much of Europe was also unprepared, Fauci concurs to a degree the observation doesn't cover. Quote, when you look around, nobody did great, except maybe one or two countries. Most everybody did poorly. Even those countries that had no political divisiveness the way we had, they did poorly. There were gaps and inadequacies in both preparedness and response that varied among different nations, end quote. More than a couple of countries across political philosophies staved off COVID for nearly a year and a half, but could not fend off multiple SARS-2 variants that emerged in let-it-rip regimes, including the United States. Indeed, by the New York Times' war on China's zero COVID program, the last standing worldwide, controlling COVID was demonized by the West. And what is the source of this divisiveness stateside that Fauci speaks of? How does one explain the largest county shifts in voting Obama 2012 to Trump 2016 in counties suffering the worst in the diseases of despair? Is Fauci, 4 decades into a career at the top of US public health, innocent of this trajectory in both the sense of understanding it and sharing in its responsibility? Did he have anything to do with the culture wars he laments? Now, the rest of the interview is a wreck. He blames Black and brown people for the government's failure of a vaccine campaign. He also waves off the notion the administration acted more in the interests of political and economic interests, omitting his own defense of reducing the recommended quarantine from 10 days to 5 on exactly those terms. He washes his hands of the failure to raise the alarm about COVID in February 2020 because he didn't want to raise a false alarm, despite all the evidence of a serious outbreak in China. He dismisses any anthropogenic explanation of the emergence of the virus, whether lab leak or out of agriculture's incursion upon wild landscapes. For goodness sakes, he says, natural occurrences occur all the time. On Next Steps, Fauci offers the technicist program of a better pharmaceutical platform and the CDC line that it need only revises academic culture of publishing results first, which, as the People's CDC external review of the CDC makes clear, doesn't touch on half of the agency's problems. Setting aside his early HIV commentary to the effect one could get infected from a toilet seat, Fauci ends the interview on the lessons he learned listening to angry gay people in the early days of the HIV pandemic. To this point, however, the American people do not show up here on COVID, save as dupes of the culture wars, while many may be. But an alert epidemiologist would frame that response in the context of an empire on the far side of its cycle of accumulation, divesting from public health and turning capital back into liquidity. Lessons learned appears the order of the day now that the pandemic has been declared over. That Johns Hopkins Coronavirus Resource Center commentary we began part 1 with ends with some recommendations. Establish uniform standards of reporting across U.S. jurisdictions. Diversify skills and collaborate across data scientists, engineers, epidemiologists, experts in law and policy, communication strategists, and more. Invest in the tools we need, including infrastructure for reporting back home tests, a much broader genomic sequencing program, and a smoother reporting system. Pass the Data Modernization Act to help push back against the chronic understaffing of public health. We need to update disease surveillance systems and data sharing networks and modernize state laboratories. In the meantime, the quant team at the People's CDC is in the middle of devising its own protocol in an effort to fill in the resulting collapse in federal COVID surveillance that we talked about in the first part of the episode. Perhaps even compiling those county numbers available state by state. Amy Maxman, who made it through the revolving door from journalism to the Council of Foreign Relations, offered these so-called radical changes to prep us for the next pandemic. And there's nothing radical about these. She does take the CDC to task, recommending that testing sites be put everywhere, not just for COVID, but for flu and STDs. She says we need to staff hospitals, but she offers no commentary how privatizing medical care sent staffing ratios in decline even before the pandemic. She says we need to reward data. As the Johns Hopkins team declared, we need to repair the patchwork surveillance system. Globally, Maxman continues, we should reward low-income countries that report their data in a timely fashion with faster access to drugs and vaccine. In essence, weaponizing the disparities the global North holds over the global South. She continues that we need to better protect workers with guaranteed sick leave for all. Maxman notes the low wages, low savings, and labor conditions workers face, but says nothing about ameliorating those circumstances, save within the very close applications of OSHA standards. Maxman declares we need to reduce incarceration, to reduce COVID's amplification in jails and the wider community. Nothing on the role incarceration plays in racial capitalism to begin with. As if such strides in social justice must be instrumentalized for this sudden epidemiological danger to everybody, brought about the very system than on changing these things on their own merits. Maxman goes on to recommending expansion of drugs and vaccines, missing that our pandemic failures emerged in the face of a record rollout, which might mean pharmaceutical production isn't enough. She also recommends increasing manufacturing such pharmaceuticals in the global South, but doesn't speak to who should own such factories, global pharma or local governments. She finishes with the need of global solidarity, but her recommendations orbit around how U.S. officials should act in, say, revising WHO health regulations. There's nothing in here how a U.S.-led world system is driving the emergence of infections in the first place. Even ostensibly technicist interventions are politically bounded in this way. The CDC suddenly released new ventilation recommendations, including 5 air changes an hour. It long knew were important, but only after declaring the pandemic over did it release these recommendations. The American Society of Heating, Refrigerating, and Air Conditioning Engineers is also coming up with a control of infectious aerosols standard 241P, with a normal mode of ventilation and an infection risk management mode of ventilation. A People's CDC expert on ventilation cited HVAC guru Joey Fox to the fact that these standards give building owners and operators the right to set which mode when. In other words, it isn't a mandate yet. The next step, the People's CDC expert declares, is to organize the public into demanding adequate indoor air quality and increasing ventilation rates from homes to hospitals to schools. As we reported in a previous COVID This Week, Ashish Jha, the White House COVID coordinator, pronounced that almost no one dies of this virus. But he is apparently worried enough now as to solicit expert projections on the likelihood of the emergence of a new variant capable of driving a spike in COVID deaths in the next 2 years. Asked individually, the experts clocked in the possibility anywhere in the range of 5 to 30%, less a calculation than a gut check. Evolutionary biologist Trevor Bedford actually ran a calculation and placed the risk at 40%. He makes an important point, largely lost on much of public health. Quote, 40% feels intuitively high. The main reason that 40% number could be off is that in today's world, Omicron-like events are now much less likely than in the world of 2020, 2021, which he ran when he ran his initial calculations. However, Bedford continues, I don't see an obvious reason for this to be the case, end quote. Why? Because, as we discussed in part 1 of our episode, SARS-2 is a highly mutable pathogen still infecting tens of thousands of people worldwide daily. Scripps Research Translational Institute Director Eric Topol considers such projections as telling, informing CNN that he thought, quote, the dismantling of data systems is a mistake, given the consensus that another highly disruptive variant could be on the way within a few years, end quote. Such disruptions are still in play for the immunocompromised, the elderly, and the repeatedly reinfected. The basics of vaccination and non-pharmaceutical interventions, hardly disruptive compared to a zero-COVID program, can offer much in the way of protection than the wishful thinking of the extreme center. Here, People CDC member and medical doctor Laura Jirmanus joined Ellen Lee and other members of the Massachusetts Coalition for Health Equity demanding hospitals where those infected with COVID meet patients vulnerable to COVID, demanding these hospitals retain their mask mandates. It's a fight that the People CDC remains in. From its external review of the CDC, trainings on using the Americans with Disabilities Act to protect masking in medical settings, to phone banking for such masking. It's a fight the People CDC will continue because one can't declare a pandemic away. You actually have to do something about it. And that's COVID This Week. You can find all our episodes on the People CDC YouTube channel. You can learn more about the People CDC and read this week's COVID weather report at our website, peoplecdc.org.